for P3 students. We will start with this presentation. And our objectives for today are to discuss the role of aspirin in acute coronary syndrome and for primary prevention of cardiovascular disease. Also talk about anti-ADP drugs and their role in acute coronary syndrome. And finally look at the aspirin for stroke prevention in AFib patients. We'll have an audience poll question. Think about this. Where does aspirin exhibit its antithrombotic effects? If you had time to think about it, aspirin imparts primarily its antithrombotic effects through inhibition of the PGH synthase or COX enzyme. And which one of these chemicals do you think is responsible for being secreted during any kind of vessel injury? And so thromboxane A2 is actually the most important one that gets secreted by the platelet in response to a variety of stimuli, and so it produces platelet aggregation in vasoconstriction. Also, prostaglandins are responsible for protecting your gut and gastrointestinal mucosa. And so what do you think is the greatest risk with aspirin? I kind of gave it away already, so it's bleeding. Obviously, with thromboxane A2 decreased, you'll have less platelet aggregation, and with prostaglandins also being decreased, the gastrointestinal mucosa will not be as protected, and therefore patients will be at high risk for gastrointestinal bleeds. Another thing to think about is how long does it take for aspirin to work, and also how long do aspirin effects last. And so aspirin starts working pretty quickly, within 60 minutes or so, and the half-life of aspirin is only 20 minutes, but platelets cannot regenerate COX, and so therefore the aspirin effects will last for the life of the platelet. And what is the life of the platelet? It is 5 to 7 days. And so the dose to achieve this platelet inhibition is usually just 100 milligrams, and that's why you see 81 milligrams used so often. Moving on to our patient case, this is Peter. He's a 50-year-old male seen at the primary care clinic. He has GERD, allergies, and no cardiovascular risk factors, and he's asking you if he should start taking a baby aspirin every day. What would you say? Well, in order to make a recommendation, you really need to calculate Peter's risk. And so we know there's Framingham risk scoring system that tells us patients who have a risk score of 5% or less or 10% or less are considered to be, or actually less than 10%, I'm sorry, considered to be low risk. And then 10% and more are moderate to high risk patients, with 25% Framingham score being high risk patients. Now, we have a meta-analysis that looked at aspirin use in patients with different cardiovascular risk situations, and this is the table here below. And so patients who have very low risk of cardiovascular events, so Framingham risk scoring of 5% or so, actually don't get that much benefit from aspirin. Yes, you can decrease MI -6, but you're really trading off with major bleeds almost just as much, with no effect on non-fatal stroke and no mortality benefit. But you can see how exponentially the benefit of aspirin increases as the cardiovascular risk of patient also increases. So patients who are at higher risk will actually experience the most benefit from aspirin, as displayed in this chart right here. What do the guidelines say? What should we do? Actually, this is a quite controversial topic now, primary prevention of cardiovascular disease and using aspirin. We have many different guidelines that kind of don't agree. We have American Heart Association and also European Society of Cardiology that says that we shouldn't be recommending aspirin to patients unless they have that Framingham score of greater than 10%. And then we also have U.S. Society or U.S. Preventive Task Force that tells us that recommendations of aspirin really are based on patient sex and age. And so they say that you could give patients aspirin if they're males 45 to 79 years of age or females 55 to 79, but you don't really get any benefit with aspirin for patients who are younger, less than 45 for men and less than 55 for women, or patients who are really old, so more than 79 years of age, where you probably get a lot of trade-off with bleeds. Then we have chest guidelines. So chest guidelines in 2012 came out, and they said, well, let's give aspirin to everyone, even if they're just 50 years of age, without any risk factors. But you have to remember that this level of recommendation is very, very low. So it's only 2C level of recommendation, which is quite low to begin with. So you can't just go around and say that patients who are 50 years of age or older should be getting it based on the level of recommendation. And then we have Canadian Cardiology Society that says that we really shouldn't be recommending any aspirin at all for primary prevention because there's a really high trade-off with bleeds, and the clinical trials that evaluated the use of aspirin didn't really take into account ACE inhibitor use or statin use, and therefore you can see how there is a controversial point of recommending aspirin for primary prevention. Well, what do we do with Peter? Well, first we have to know his Framingham risk. Based on what he told us, he doesn't smoke, his blood pressure is fine, he's not on any blood pressure meds, and his cholesterol looks great, so his CHD risk is only 2%. And based on that risk, he's really not going to be benefiting from aspirin. Only by chest guidelines will he be recommended aspirin, but remember that's only a level 2C recommendation. But if Peter had hypertension, hyperlipidemia, then his risk starts going up to greater than 10%, and at least by Ford guidelines, he would be benefiting from aspirin. Now we have John. John is a 60-year-old male who's brought to your hospital with crushing chest pain, 9 out of 10, unrelieved by sublingual nitroglycerin. What's the first medication that John should be given? So now think secondary prevention. So these patients are already having an MI, so what should they be getting? Aspirin. Aspirin is the first thing that we give patients when they come into the hospital with a rule-out MI. Actually, they get that en route, so usually when they're being transported by EMS, they will already get aspirin by the rescue workers. And so I'm sure you've heard of core measures. We have ACCHA guidelines that tell us that patients that are non-STEMI or STEMI should be getting these antiplatelet therapy with aspirin or P2Y12 receptor antagonists or glycoprotein 2B3A inhibitors. And this is part of the core measures that Dr. Gross discussed with you earlier. John's diagnosed with STEMI. He's been taken to the cath lab, where he receives a stent to the left anterior descending artery. So you're reviewing his medication profile. What antiplatelet drug would John benefit most from receiving? Well, first of all, what is a cath lab or PCI? Well, obviously John had a blockage in his coronary artery, and so we will take this catheter and insert it inside his artery, inflate either a balloon or deploy a stent that will mesh or smash this plaque and hopefully improve the blood flow to the heart. And what do you think is the problem with doing this? Obviously, this is a very thrombogenic procedure because you're providing a lot of vascular injury, and so you have to protect this stent from thrombosing by giving antiplatelet therapy. Aspirin has great data in acute coronary syndrome. We have from 1990s and late 80s where aspirin was studied in unstable angina patients. Patients aspirin versus placebo. Patients with aspirin had lower incidence of death or MI compared to placebo group. Aspirin was also associated with much lower rates of reocclusion compared to the placebo group in the ROCKS trial. And then finally, in our acute myocardial infarction population, so these are patients who had episode of MI within 24 hours, the patients who received aspirin had lower rates of MI and death compared to the ones that didn't in the ISIS-2 study. And then we have the ETCC meta-analysis for patients for using aspirin in patients after MI. And they looked at patients who were very high risk, so prior history of MI, unstable angina, prior PCI, stroke, AFib, and PVD, and give them aspirin or placebo, and looked at the endpoints of non-fatal MI, non-fatal stroke, or vascular death. And so the results were that the patients who received aspirin reduced their non-fatal MI risk by 1/3, the risk of non-fatal stroke by 1/3, and the risk of vascular death by 1/6. And with patients with prior history of MI had vascular events over 2 years reduced compared to placebo, and same thing with the prior history of stroke. So this meta-analysis shows us that aspirin has great data in high-risk patients for secondary prevention of outcomes. Well, what about anti-ADP drugs, or P2Y12 receptor antagonists? Well, in order to understand this, you kind of have to look at the platelet and see what's happening. So we talked about aspirin and how it binds to the COX-1 enzyme and therefore decreasing the production of thromboxane E2. But you can see that there's so many different ways that the platelet can be activated that it's really an incomplete platelet inhibition. And so therefore, we need to add another agent to this mix to make our platelet inhibition complete. We can either add PAR1 antagonists, we can add ADP2 P2Y12 receptor antagonists such as ticlopidine, clopidogrel, prasugrel, anticoagulation, all of our anti-ADP drugs, or you can give a glycoprotein 2B3A inhibitor that will hopefully prevent the binding of platelet at the end. And so we have 3 agents on the market currently. We have clopidogrel, prasugrel, anticoagulation. Clopidogrel is a prodrug. It needs to be activated by 2-step metabolism in the liver before it can bind to the P2Y12 receptor. We also have the prasugrel that only needs 1-step metabolism. It's also a prodrug to be activated. And then finally we have ticagrelor that does not need to be activated and just binds to P2Y12 receptor antagonist, P2Y12 receptor, because it's an active drug. And so comparing all these P2Y12 receptor inhibitors, we have clopidogrel. It's a prodrug. It has the 2-step cytochrome P450 conversion, so 2C19 patient variation is quite common, and there's large amount of patient variability in response. There's also drug interactions with PPIs, and the onset is delayed, so it takes 4 to 6 hours for the clopidogrel to work. It's also irreversible inhibition of the P2Y12 receptor, so you have to wait for the life of the platelet for clopidogrel to reverse itself. And this could be problematic for patients who are undergoing CABG or other major procedures because you have to wait 5 to 7 days before you can do a procedure. Prasugrel, in comparison, is also a prodrug, only 1 single-step cytochrome P450 conversion. You have multiple enzymes capable of this conversion. Therefore, it lacks the patient variability compared to clopidogrel and provides much more potent platelet inhibition. The onset is only 30 minutes compared to 4 to 6 hours with Plavix, but you also have that irreversible inhibition of the P2Y12 receptor. And finally, ticagrelor, not a prodrug, does not require metabolic activation, very quick onset, 30 minutes, and it's reversible. So the functional recovery of circulating platelets can happen within 48 hours, which could be great for some patients. So issue with clopidogrel, long onset, must undergo that 2-step metabolism, offsets 5 to 7 days, and irreversible binding. And then it has that variability of response. So 25 to 30% of patients achieve less than 25% inhibition of platelet activity. And this is most important patients who are obese or diabetic, which was shown in Triton-TIMI trial. Therefore, FDA posted a black box warning us of this genetic variability. And so we have multiple platelet function assays that can measure this variability in patients, and there's several ones available. There's Verify Now, VASP, TAG platelet assays. None of them have really been studied, and we don't know which test best predicts clinical outcomes. They're all very expensive as well, so $500 or so per test, which is not reimbursed. And we don't have specific recommendations on genetic testing due to limited studies on results of this testing. I'm going to break for now, but we will return shortly with part